Welcome, everybody. Thank you so much for joining. I'm Dinda, Elliott, the Executive Director of the Fairbank Center for Chinese Studies, and I'm absolutely delighted to have today with us Arthur Kleinman, who is the Rabb Professor of Anthropology in the Faculty of Arts and Sciences. He is also the Professor of Global Health and Social Medicine and a Professor of Psychiatry at the Harvard Medical School, a man with many titles. So Arthur, first I owe you a congratulations, which is that you recently celebrated, number one, 55 years of doing healthcare research in Chinese society, and 46 years of doing this research in mainland China. Furthermore, this past summer you received the insignia for the Magnolia Award in Shanghai, honoring your work in illness, healthcare, and aging issues in China. So tell us a little bit about what changes you've seen over the years in China's approach to healthcare and aging.
Well, thanks, first of all, for interviewing me, Dinda. I appreciate it. And I should point out, by the way, something that I don't regard myself as a China scholar. I regard myself as a medical anthropologist and a psychiatrist who's performed half a century of research, and it happens to be in Chinese society. Okay? What that means is that my principal interests have not been so much China per se, as China representing almost 1/4 of the world's population in the setting of anthropologically important questions and psychiatrically important questions. When I first went to China in 1978, it was a very poor country, and in Beijing, Shanghai, there were basically no cars on the road. There were buses. At night, the buses would turn their lights off, supposedly to save electricity, and would turn them on when they came to a corner, and you'd freeze, hoping they wouldn't hit you.
I remember that.
You remember that?
Yep.
Yeah. And of course, if you went to department stores in Shanghai, there was almost nothing on the shelves to buy.
What did healthcare look like in those
And
days?
healthcare at that time had really come out of the Cultural Revolution, which had ended only 2 years before, and was organized around two kinds of problems. One was the recognition in the days of collectivization that barefoot doctors would be able to do a lot for public health. And second was the recognition that barefoot doctors were not going to do much for care because they simply didn't have the skills to provide appropriate care. And this has had a long tail in healthcare right to the start. So the very set of things that were put in place in public health, where barefoot doctors played a central role, vaccinations, control of water and sewage, that has had a huge population impact over time. And along with the raising of 800 million people out of poverty in that 40-year span, really unprecedented, that's had the enormous effect on health. But it's also had another effect on health that was what the late sociologist at Columbia, Robert Merton, would have called an unintended consequence. And that unintended consequence is that peasants working with barefoot doctors and workers working in urban areas with very low-level doctors came to realize these doctors really couldn't provide effective treatments. And so they got into the habit of going to the major hospital, and that still goes on today. So China today has really only begun to build a primary care system, and it has this enormous hospital system, which still takes up much of the money, and leads to situations like the following that I saw this summer, which is a clinic at a well-known hospital in Shanghai, in which 500 patients were seen in 2.5 hours by a professor, 2 assistant professors, 2 residents, and 2 postdoctoral fellows. You can't see
horrible care. Right.
You can't see patients at that rate.
Right.
And these are really good doctors,
Yes.
by the way. They're really skilled. Okay, but you can't see a patient every 3 minutes, and and give any kind of care. So
Right.
that's a structural problem that really needs to be fixed. And we have people like Winnie Yip here at Harvard who look at the way policies are
I
developed.
was just going to jump in
But-
to ask you, this idea of building 10,000 bed hospitals, right? That
Yeah,
seems to be
yeah,
China's obsession.
yeah,
It's the bigger the hospital, the better.
Yeah.
And yet there aren't enough doctors to do primary care. So how are they going to wean themselves away from that?
Well, I think this is going to mean the impact of the middle class that China has developed so impressively, demanding high quality care. And that's what they're doing today. And I think the Chinese government is recognizing this. After all, they're doing some extraordinary things that we never hear about them because our press will not publish positive things about China. But for example, building a long-term care insurance system, which we don't have in the United States, is extremely important, especially as China ages. And that's where my work is focused now, on aging China, so that in 2050, a third of the Chinese population, almost, will be over 65 years of age. And at that time, 25% of the American population will be over that. And in both countries, the most rapidly growing population will be those over 85 years of age.
And were you saying that they're actually making real progress in
Yeah,
terms
they're
of
making
developing
progress in
long-term
setting
care
the-
insurance?
Yes, and setting the basis for long-term care insurance. And that's something we really need in the United States. Because as you get older, much older, you average, let's say, above 75 years of age, 3 chronic diseases, and you need high-quality care for that. Now, the problem we have is a problem that has to do with the enormous role of bureaucracies and of financial interests in our healthcare system. So that in America, for example, we don't measure quality care. We measure institutional efficiency, which is simply how an institution like a big hospital does. And in China, they do more or less the same thing.
Well, I gather they've sort of studied
Yeah, so the
what we did
real
in the States,
possibility
right?
for AI, in my view, in the future, which has many limits and problems with it, from privacy through making the situation worse by driving practitioners out of practice and substituting for them possibly. If that happens, everything will be worse with AI. But AI has the possibility of actually measuring the quality of care, measuring the quality of clinical relationships, of communication, and things like that, which would really give us a view of the quality of care like we've never, ever had before. So I'm both a little pessimistic and a little optimistic about the future. And in terms of the relationships between the countries, I'm with my late colleague Ezra Vogel. I think there was no reason to make China an enemy, and that we are strategic competitors, and our own nationalism have buoyed the nationalism in China, and their nationalism has buoyed our nationalism, and now we're simply headed in the wrong direction. And it seems to me that this is where universities become enormously important, because through research and teaching, we can have a very big impact. Over the years that I've been working with Chinese, I have trained many of the academic psychiatrists and anthropologists in Beijing and Shanghai, and Changsha, another place that I worked in. And my feeling is that, it's those connections, those ties, that are really important. And if we can continue those across all areas of research, then you have the basis for what happened, I think, at the end of the Cold War, which is that our relationships with the Soviet Union across science helped set the grounds for what would be broader sets of relationships in the cultural, political, economic spaces.
And yet, do you see growing pressure to kind of scrutinize the kinds of academic exchanges and dialogues that you're talking about, or do you feel like in your realm of
my
health
experience has been really good. My experience in China has been really good.
Sure.
My areas, I introduced the modern idea of depression into China, okay? And if you look at
So
that,
when did that?
I
Tell
did
us
that-
a little bit about
I
that.
did it with my first set of studies, which ran from 1980 to 1983 in Shanghai, and I showed that the huge number of people who were labeled as having Shenjing Shuairuo, neurasthenia, could be re-diagnosed from a Western perspective as having depression, and had the advantage that you could actually use antidepressants and psychotherapy to help people.
And did China start doing that in the
Yeah,
1980s?
and they absolutely. So what happened was that the first, it's quite interesting and a sign of what you want to have happen when you do research. So first the senior psychiatrist at that time said, no, it can't be right, this can't be right. And all their juniors said, yeah, this is right. Okay. And then as China opened up, it kept opening up, then the case was very quickly made, okay? But I did some other things as well. I mean, those were the first, mine was the first study, as far as I know, in 1980 by an outsider of survivors of China's Cultural Revolution. And, my book, The Social Origins of Distress and Disease, Neurasthenia, Depression, and Pain in Modern China, was as much about political trauma as it was about psychiatric diagnoses. But what I've always believed is that in the advancement of science, not just biological science, social science, and the humanities, we really advance a discourse that changes how cultures work. And I think I've seen that throughout medicine. So, for example, there's attention today to issues in quality care in the doctor-patient relationship, which you never saw in China in the 1980s. Now, part of that has come out of this evolving discourse. Part of it came out of a very serious problem, which I also studied much later in China in the 2010s, which was the development of the Yuan Guanxi Wenti, a serious problem in doctor-patient relations, where patients began to think that doctors were there only for their own interests.
Right.
Okay? And so you had it that, because China doesn't have a medical legal system, there was no way to resort to courts with this. So people took it out physically and psychologically on health professionals.
But are you talking about patients feeling like they had to build guanxi with their
No, quite the opposite. It was a critique of the doctor-patient relationship, which patients said, this is worthless. You haven't done anything for me. You're using these tests just to increase the amount of money you generate. And then patients would get so angry they would attack doctors and nurses.
I see.
That was the Yuan Guanxi Wenti.
Right.
Some doctors, a few doctors were actually killed by patients. But many were threatened, and the way that has evolved is rather typical of the way things get solved in China. Now you have a local party secretary who steps in and says basically to the patient and family, how much do you want for this problem? Okay, they made an error. How much do you want? And they name a sum. Then he turns to the head of the hospital and says, well, is that a satisfactory, you're willing to give that? Is that a suitable amount? And then he negotiates the result. That's not a great way of doing it, but it's a lot better than physical intimidation.
You mean that's in payment for poor care, basically?
Yeah, is it a payment for poor care? In part, yes, when care is poor.
Yeah.
And part of it is a problem that China has that I think to a much greater degree than the U.S., which is the expectation of what biomedicine can achieve is extraordinarily high in China. And so the idea that some treatments may not work, and you may actually die from a disease or get sicker, not because anyone has made a mistake, but because we simply don't have the effective treatments. I think that the Chinese are not generally at that point. They're at a point where they expect that you go into a hospital with a serious illness, you should get better.
So there's such a belief in the science that the science has to work.
There's a big belief in the science. Absolutely. Yeah.
Interesting.
Now, what's interesting also from an anthropological standpoint in that period of time when you had the Yiwan Guanxi Wenqi was really acute, traditional Chinese physicians, Lao Zhengyi, never got this problem. This was a problem entirely with biomedicine, suggesting that, the traditional Chinese doctors spend more time speaking to patients, usually have better relationships. That's what exactly should happen in biomedicine.
Yeah, I once went to an acupuncturist who told me that his patients very often end up crying, and it's partly because he's actually there talking to them.
Right, so he's talking, listening.
Yep, he's listening.
That's part of the role of the physician classically
Yep.
has been to hear what the problem is and listen to it.
I'm curious about, you described the 500 patients being seen in, what was it, 1 hour? Something like that.
2.5 hours.
2.5 hours, okay.
Yeah.
So I'm curious, because all these Chinese doctors who are wonderful, etc. So what do they say? They must be tremendously frustrated by that system.
Yeah.
So
they want to, but it's not like this is news globally. Look at the United States. 50% of American doctors experiencing burnout. Okay, so it's happening all over the world.
Right.
And in my view, it's happening simply because of our economic structure is such that we have emphasized efficiency to the loss of care.
Right.
Okay?
It's so interesting because, as you've been saying, the Chinese in many ways studied the American way for many, many years. Yeah. And now it seems like both countries have a lot to learn from each other in terms of trying to solve the problems, right?
I think
medical problems.
This is what I'm working on with our social technology for global aging project at Harvard. That we're trying to learn from China to help the Chinese, but also to help us in the United States. Are there ways that technology, appropriately used socially and embedded socially in the actual experiences that elderly people are having, can improve a number of things? For example, both societies are emphasizing aging at home.
Mm-hmm.
So are there devices that can help aging at home? We're looking at everything from elevators on buildings to assistive technologies that help with climbing stairs.
And are you working with Chinese at this point, working together? Or?
6 schools, we have faculty from 6 schools at Harvard, and students as well. And we work with colleagues in China from Tsinghua University, Fudan University, Minzu Dashua from the Nationalities University, from several other universities. And this has been really interesting. We've learned a lot about elders' needs and concerns. And also we've learned that one of the problems with technology is that if you don't begin with a clear understanding of the social circumstances it's going to be put into, it can have a negative effect, untoward, unexpected, unanticipated effect that's negative. And you don't have to have that if you bring together, in our case, anthropologists and physicians with people doing the technology, engineers, design people. You can have a better outcome.
Wow,
in that
that's
that's what we're aiming for, and that's what we have. I can't really say that we've had big successes so far, but what we have had are exemplary examples that really are exemplary in terms of pointing toward the future, and we hope that this will be something that will suggest a method of proceeding that's thoroughly interdisciplinary, and in which you can't do a health intervention technologically without someone like an anthropologist who can work on the ground with people to understand how it's going to be used and taken up, etc.
That's just so thrilling to hear that you're not only bringing these disciplines together, the anthropologist together with the physician and the scientist, but working with colleagues in China.
We have a policy side
really
to this.
Thrilling. Yeah.
We had a conference this last summer on rural health for the elderly and health policy for the elderly. So the Minzhongbu, the Ministry of Civil Affairs, the Ministry of Health, local, provincial officials are very concerned about rural health and how to deliver health to people who are in particularly remote areas. There are all kinds of issues that are relevant to China and relevant to us, okay?
Yeah.
And one of them is, as I mentioned early in this, is policy. And so we have a lot of work with Winnie Yip, David Bloom from the School of Public Health, looking on policies that are pertinent to aging in China, but also pertinent to the United States.
You've just struck such an optimistic and positive note. I'm thrilled to hear about this work that you're doing and that others at Harvard are doing. I wonder, in the context of this academic exchange and collaboration that you're overseeing and working on, are there things that you worry about in terms of the U.S.-China? We know the U.S.-China relationship is terrible. So what impact will that have on academic exchange? What do you worry about?
Obviously, if it gets much worse and the like, it will affect the kinds of things that we're doing. I would say that aging is an issue that is so in the face of leaders in China and so recognized in the United States that this is an area that you can clearly work on. And many aspects of health, I think, provide that opportunity. So, for example, in my case, I was able to do anthropological research, say, for example, on the survivors of the Cultural Revolution, that I could never have done if I simply went in as an anthropologist and said I'm going to study the survivors of the Cultural Revolution. But instead, I came in with a health interest. What is Shenjing Shiro, that is neurasthenia? What is depression? Why do so many people who've had bad experiences in the Cultural Revolution have this problem? What can be done about it?
And this is why your work is so important, even beyond the specifics of your work, just that at this time when so much other work can't be done between or isn't being done between the United States and China, you are still continuing. So thank you very much for that, Professor Kleinman. Thank you for joining us today. And we're going to get you back again for another conversation. Thank you.
My pleasure.